Okay, welcome to Chapter 6 in Gunstream. Today we'll be discussing bone tissue and bone structure. So we're going to describe the basic functions of the skeletal system. We'll describe the structure of a long bone and the microscopic structure of compact bone. We'll talk about the different types of bone formation, including intramembranous and endochondral ossification. And we'll compare the functions of osteoblasts and osteoclasts and osteocytes. We'll talk about the different divisions of the skeleton and describe the surface features of bones. We'll ID the bones of the axial skeleton and compare the skull of an infant and adult. And we'll compare cervical, thoracic, lumbar, and sacral vertebrae. And we'll ID the bones of the appendicular skeleton. We'll also talk about articulations and disorders of the skeletal system, including disorders of the joints, such as arthritis. So when you think of the skeletal system, what is it that immediately comes to mind? And some of the features that are immediately evident are the fact that it provides support for the rest of the body by providing a framework over which to hang the soft tissues. It protects a lot of our vital organs. Our brain and our spinal cord and brainstem are housed inside our cranium and vertebral column, and our heart and lungs are housed inside our bony thorax, while our bladder and some of our reproductive organs are housed in the pelvic girdle. It's also an attachment site for skeletal muscle, and this is basically how we achieve movement through the combined action of the skeletal muscle and the skeletal system at special joints that are called diarthroses and amphiarthroses. These are joints that have some degree of movement. It's a place where blood cells are produced. The myeloid stem lines are generated in the red bone marrow. These include the thrombocytes, the erythrocytes, and the myeloid division of the leukocytes, the granulocytes, and the macrophages. It's also important as a mineral storehouse. It stores a lot of calcium and phosphorus, as you know, but it's also a storehouse for other minerals as well, so the body can tap the skeleton when it needs to essentially replenish its supply of these important electrolytes. So bones are made up of a wide variety of tissues. The bone tissue is the bulk of each bone, and there's four basic types of bone based on their shape. Long bones, which are longer than they are wide or thick. Short bones, which have essentially approximately the same dimensions in all dimensions, but they may have somewhat irregular shapes. Flat bones, which aren't perfectly flat, but basically flat. And irregular bones, such as those of the vertebrae and of the pelvic girdle, which we'll address shortly. So the structure of a long bone consists of the epiphysis, which are the terminal ends of the bone. You can see here the proximal epiphysis and the distal epiphysis. The articular cartilage, which pads and protects the ends of the long bone from damage, especially in the context of a movable joint where bone on bone can produce bone spurs and damage to these regions of the bone. The diaphysis, which is the shaft, you can see here, and the medullary cavity, which is where the marrow is housed. Now in long bones of the adult, this is generally filled with adipose tissue, while in the developing infant, this is made up primarily of red bone marrow. The endosteum is a connective tissue membrane that supplies blood vessels and also a source of new bone cells for the growing and remodeling bone. And the epiphyseal disc, which is essentially where the diaphyses and the epiphyses meet during long bone longitudinal growth, which lasts until the end of puberty. This is made up primarily of cartilage. This is where spongy bone tissue abuts cartilage tissue. But at the end of puberty, what happens is that these epiphyseal discs are replaced with bone scars, and from that point on, the only change in bone structure is one of thickness in response primarily to applied force. The periosteum is again, a membrane that lines the bone, the endosteum lining the medullary cavity, and the periosteum lining the external portion of the bone. It's again a connective tissue membrane that supplies now blood vessels, nerves, lymphatics, but is also a source of bone cells, the osteoblasts and the osteoclasts. Spongy bone is what makes up the interior of the long bone, as well as the interior of flat and irregular bones and the epiphyses of long bones. It consists of trabeculae and spaces that are filled with red bone marrow, and this is, of course, where hematopoiesis takes place. It reduces the bone weight without reducing its strength. The reason for this, number one, is it's less dense than compact bone. In addition, due to the network of trabeculae that run through this tissue, it allows distribution of applied force so that you're less likely to damage the bone in the event that it is utilized. So in a sense, it acts in a similar fashion to the way that snowshoes distribute weight when you put them on and walk over the top of the snow. Snowshoes have a broad base, and they distribute your body weight over a wider surface area, and the result then is that you're less likely to sink into the snowbank, because at no one point is the force so great that you would actually fall through the crust. Same thing is true in spongy bone. Due to the trabeculae that are present below the compact surface, you distribute force over a wider area. The result is that the bone is less likely to crack. Compact bone is found in the wall of the diaphysis as well as its surface. It's a tightly packed tissue with very little space between it. It's strong and it gives supportive strength, and is made up of a very special arrangement of extracellular matrix and extracellular matrix cells. This is again a type of connective tissue. Remember, the connective tissue is characterized immediately by the fact that you have relatively few cells in a vast volume of matrix. So you can see here that in compact bone, the bone cells lie inside little pits called lacunae. Essentially what happens as these bone cells lay down matrix is they trap themselves inside their own secretions, and from that point on they're unable to move. So the only way that we can supply nutrients and remove waste products from these trapped osteocytes is through cell-cell connections that are cytoplasmic protrusions of the plasma membrane that radiate through canaliculi that connect the bone cells across regularly spaced layers of compact bone tissue, which we call lamellae. This is how we are able to get oxygen and nutrients to the bone cells so they can maintain the matrix, while at the same time removing waste products so they don't build up to the point where the cells become toxic and die. So compact bone structural unit is called the osteon. You can see an example of an osteon here. Okay, this whole thing, whole circular cylindrical area is an osteon. The osteonic canals and the lamellae are the major features, and there are also foramina that run through the osteons and canaliculi, which connect the osteocytes with each other. Spongy bone, by contrast, does not have an osteon structure. It gets nutrients by diffusion through the canaliculi, as do the osteocytes that are present in compact bone. The difference, though, is that in spongy bone we don't see this regular lamellar structure that we see in compact bone. So when we talk about the components, what we have are central canals called haversian canals that radiate up through the middle of the osteon. This carries blood to and from the bone tissue. There are also perforating canals that run at right angles to these central canals, and then concentric lamellae that radiate out from the central canal that are populated by the osteocytes lying within their lacunae, connected to each other via these canaliculi. The canaliculi and the lacunae are the openings in the compact matrix, and cells themselves sit inside these openings and attach to each other as a result of these cytoplasmic extensions that radiate through the canaliculae. You can see as we move from the periosteum through the compact bone, we eventually reach the spongy bone, and you can see here that deep to that you're going to find nerves, blood vessels, and of course yellow marrow in the bones of adults. And the spongy bone and the medullary cavity serve a double purpose. One is to lighten the bone, and of course the other is to distribute force applied to the bone and also serve as a site of hematopoiesis when necessary. Under emergency conditions, the yellow marrow can be converted to red marrow in order to fill any red blood cell debt that we may have occurred as a result of an inability to keep up with blood supply by hematopoiesis. Ossification is the process of bone formation that occurs during the 6th or 7th week of embryonic life. There's two types of bone formation we want to discuss: intramembranous and endochondral ossification, which we'll detail here.
Bone formation, also known as osteogenesis or ossification, is the process by which bone tissue replaces embryonic connective tissue to form the skeleton. From childhood to early adulthood, ossification lengthens and thickens bone. In addition, the process of ossification is used throughout life to remodel bones. There are two methods of prenatal bone formation. During intramembranous ossification, bone is generated on or within fibrous connective tissue membranes. As the process begins, mesenchymal cells differentiate into osteoblasts in regions called ossification centers. The osteoblasts secrete osteoid or uncalcified bone matrix. Over a few days, osteoblasts become osteocytes, and calcium and other mineral salts are laid down, hardening the matrix. The bone matrix develops thin columns of bone called trabeculae, which fuse to form spongy bone. Blood and lymphatic vessels grow into the surfaces of the newly formed bone and develop red bone marrow. Outside of the bone, a dense layer of connective tissue called the periosteum forms. Most outer layers of spongy bone are eventually replaced by compact bone, but the center remains spongy. Intramembranous ossification also occurs with skull bones in childhood. At birth, skull bones are separated by fontanelles, or soft spots, and sutures, immovable joints made of fibrous tissue. Fontanelles in the fetal skull allow for easier passage through the birth canal and rapid brain development. Up until adolescence, the fontanelles slowly ossify into sutures, providing the brain with greater protection. Endochondral ossification, the replacement of cartilage by bone, occurs in most bones of the skeleton. The process begins when embryonic mesenchyme condenses, forming the cartilage model, the shape of the future bone. The model grows within the fetus. Lengthwise growth is attained via interstitial growth. Width is attained via appositional growth. A nutrient artery penetrates the perichondrium, increasing nutrient availability to the cells. Osteogenic cells are stimulated to differentiate into osteoblasts. These cells secrete matrix beneath the perichondrium that forms a thin shell of compact bone known as the bone collar. As the perichondrium begins to form bone, it is now called the periosteum. The bone collar reduces diffusion to the cartilage inside the model, depriving it of nutrients. Capillaries grow into the disintegrating cartilage, delivering osteoblasts. The new growth forms a primary ossification center, an area where bone tissue will replace most of the cartilage. Osteoblasts deposit bone matrix, building spongy bone trabeculae. The growing model is gradually remodeled. The cavity fills with capillaries and red bone marrow. Ossification proceeds, forming the main portion of a bone, known as the diaphysis. Around the time of birth, blood vessels enter the epiphyses, the ends of a bone, forming secondary ossification centers. Secondary ossification differs in that no medullary cavity forms, and ossification proceeds outward. As a result, the interior of the epiphysis remains spongy. Secondary ossification leaves a thin layer of hyaline cartilage covering the epiphyses. This is known as articular cartilage, and it reduces the friction and shock in bone joints. The change to the epiphysis also forms the epiphyseal plate, a layer of hyaline cartilage that enables the diaphysis to grow in length.
Continued growth in diameter is due to the formation of compact bone beneath the periosteum. Remember that that's the external connective tissue membrane that surrounds the outside of the bone. And continued growth in length takes place at the epiphyseal disc. The cartilage grows on the epiphyseal side, while the cartilage is converted into the bone on the diaphyseal side. The osteoblasts and osteoclasts continuously reshape the bone as it grows. This growth in length continues until the end of puberty, where the epiphyseal plate is completely replaced by bone and the epiphyseal line is all that remains. And from that point on, the only change in bone structure is a change in density and a change in width, which we call appositional growth, that responds as a result of force that's applied to the bone. Bone is continuously remodeled by osteoclasts and osteoblasts. Osteoblasts, remember, lay down the bony matrix while osteoclasts dissolve it, and so they act as a team in order to respond to applied force. Remodeling is affected by physical activity, calcium intake, and also age. The bottom line with the skeletal system is if you don't use it, you lose it. So if you're not active, you're going to lose bone density as a result of essentially reducing osteoblast activity while not having an equivalent effect on osteoclast activity. This is one of the reasons why, as we age, we begin to generate softer bone tissue. This is a condition called osteoporosis, and it's a dangerous condition because even minor accidents can result in shattered bone as opposed to simply a bump or a bruise. The skeleton is split into two divisions. The axial division, which are the bones along the longitudinal axis of the body. This includes the skull, the vertebral column, the sternum, the rib cage, and the appendicular skeleton, which include the pectoral and pelvic girdles and the bones of the upper and the lower limbs. Now, the bones of the skeletal system are pictured here. I'm not going to go through each bone. I have a nice video that'll be appended to the end of this podcast that'll sort of run through that for you. But what I did want to point out is that you are responsible for knowing these bones and knowing their articulations, meaning what they touch, either above, below, laterally, or medially, or proximally, distally, or anteriorly or posteriorly. To take an example, okay, we could take the humerus, the bone of the upper arm, and I would expect you to know that it articulates distally with the radius, the bone on the thumb side of the forearm, and the ulna, the bone on the little finger side of the forearm. It articulates proximally with the scapula and also with the clavicle, and it articulates medially with the scapula and the clavicle as well, forming the familiar shoulder joint. Okay? If we were to take the femur, the bone of the upper leg, I would expect you to know that it articulates distally with the tibia, it articulates anteriorly with the patella, your kneecap, and it articulates proximally and also medially with the bones of the pelvic girdle, known as the coxal bones, here and here. Okay, so that's how I want you to approach knowing the skeletal system. It's a good idea to break the bones into their component parts and work through them day by day. We'll run through a selection of the bones here in just a minute, but this is the kind of thing that takes practice, and flashcards are an excellent way to familiarize yourself with the bones of the human skeleton. So let's take the skull first. It's divided into two segments, the cranium and the facial bones, which are joined together by sutures, which are a type of immovable joint. Remember that the functional definition of a joint is where two bones come together, and there are various functional classifications of bone based on degree of movement permitted. A diarthrotic joint is one with the greatest degree of movement, an amphiarthrotic joint a slight degree of movement, and a synarthrotic joint no movement whatsoever. Several of the bones possess sinuses. Sinuses are open spaces inside bone that lighten the bone. In the case of the sinuses pictured here, they serve as connections to the nasal cavity. They're called the paranasal sinuses. They also serve to lighten the bones of the face, and they are also important in phonation, the production of speech and of sound. So you can see here that we have sinuses in the frontal bone, the main bone of the forehead. We have sinuses in the sphenoid bone, which is nicknamed the keystone of the cranium because every other cranial bone attaches to it. We also see sinuses in the maxillae, the bones of the upper jaw, and in the ethmoid bone, which sits atop the nasal cavity and articulates inferiorly with the vomer, the bone of the nasal septum, and articulates posteriorly with the sphenoid bone and laterally with the maxillae. So it's an unusual looking bone in the sense that it has an M shape. If you look at it head on, it's one of those bones that isn't entirely visible until you disarticulate the skull. And again, I've got an excellent video that I'll append to the end of this podcast that'll show again the orientation of these different bones. The frontal bone is the anterior part of the cranium. The parietal bones form the sides and the roof of the cranium, and they sit behind the frontal bone. The occipital bone is at the back of the cranium, and the temporal bones are inferior to the parietals on each side of the cranium. They possess a special articulation with the mandible. The temporomandibular joint is the only movable bone in the skull, the lower jaw. It's sometimes abused in a condition called temporomandibular joint syndrome, or TMJ, that results usually from a misalignment of the upper and lower jaw that causes the joint cavity to become stressed and inflamed, and this produces headache, muscle pain, and also, because it's often the result of grinding the teeth at night, a reduction in enamel on the molars particularly. The sphenoid bone is the keystone of the cranium. It forms the lateral posterior portions of the eye orbits, the lateral portions of the cranium, and it's anterior to the temporal bone. while the ethmoid bone forms the anterior portion of the cranium, including the medial surface of the eye orbit and the roof of the nasal cavity, while the conchae are on the lateral walls of the nasal cavity, and they form depressions and elevations that allow the inhaled air to come into extensive contact with the mucous membranes that line the nasal cavity so that the air can be warmed, humidified, and adequately filtered before it enters the delicate lung tissue. The superior and middle nasal conchae are actually features of the lateral portion of the ethmoid bone, while the inferior nasal conchae is in fact its own bone. It is again also found on the lateral wall of the nasal cavity. The maxillae form the upper jaw and the anterior portion of the hard palate, as well as part of the lateral walls of the nasal cavity and the floors of the eye orbits, and they contain a sinus known as the maxillary sinus, which is continuous with the nasal cavity. It's part of the paranasal sinus group. The palatine bones form the posterior two-thirds of the hard palate and the lateral wall of the nasal cavity, while the zygomatic bones form the cheeks and the floor and the lateral walls of each eye orbit. The lacrimal bones form on the medial surface of the eye orbit, and they contain the lacrimal canals through which tears flow into the nasal cavity as they make their way across the surface of the eyeball. The nasal bones form the bridge of the nose. The vomer is in the midline of the nasal cavity and forms the nasal septum with the ethmoid bone. The inferior nasal conchae are attached to the lateral walls of the nasal cavity, and the mandible is the lower jaw bone, the only movable skull bone. Okay, this is an anterior view of the skull, and you can see here the frontal bone, the nasal bone forming the bridge of the nose. Here is the maxilla, the upper jaw, the mandible, the zygomatic bone, and then as we move back into the orbits, you can see the lacrimal bones here in blue. Behind them, you'll see portions of the ethmoid bone, and then at the very back of the orbit, in sort of light purple, you can see the sphenoid bone, the keystone of the cranium. You can see embedded into the upper and lower jaw, the mandible down here and the maxilla up here are of course the teeth. Your teeth come in several shapes. The incisors are the flat slicing teeth in the front part of the jaw. They're laterally bounded by the canines, which you probably know better as your fangs, for slashing and tearing food, and then lateral to those and posterior are the premolars and the molars, which are primarily for crushing and for grinding. You have 32 permanent teeth. Remember that 4 of those are your third molars, known as your wisdom teeth. They often have to be extracted in the event that they don't erupt from the upper and lower jaw vertically. If they erupt horizontally, they will crimp the teeth, and your dentition will misalign in a condition known as malocclusion. So the fix for that generally is to have these teeth surgically removed. They generally erupt in your late teenage years to your early 20s. Looking at the top part of the cranium, we can see the sphenoid bone here in purple behind the frontal bone and the zygomatic bone. Behind that you can see the temporal bone, and in light blue here the parietal bone. Okay, a lateral view will show us a better view of these bones. You can see here again frontal. This is the sphenoid, the temporal, the parietal, the occipital. There, of course, is the mandible, the maxilla, the zygomatic, the nasal bone, lacrimal, and the ethmoid bones. A couple of other features we need to note. The styloid process of the temporal bone is a point of attachment for jaw muscles. We also note the articulation between the zygomatic and the temporal bones in here. This area here from the zygomatic bone that projects posteriorly to articulate with the temporal bone is called the temporal process of the zygomatic bone. That's this. And this area here, this arm that reaches out to articulate with the zygomatic bone, is called the zygomatic process of the temporal bone. This is the external auditory canal. This is how sound waves reach the eardrum. It leads into the inside of the skull. The internal acoustic meatus is basically a hole that runs all the way through the temporal bone and serves as a passageway not only for sound to get to the middle and the internal ear, but also as a passageway for the vestibulocochlear nerve. You can also see the occipital bone at the back of the skull, which articulates with the parietal bones. Notice that the bones of the cranium and the facial bones are held together by these sort of zigzag lines. These are called sutures, and they're a special type of joint. They call it synarthrosis because they do not permit movement. If we remove the mandible and look at the skull from the underside, we can see several features. The foramen magnum, this large hole here, that's really Latin for big hole, is where the brainstem and the spinal cord join. The brain, of course, sits inside the cranial vault. These are the occipital condyles, and they articulate with the atlas, which is the first cervical vertebrae at the superior articular facets, and they allow the head to nod back and forth, yes. You can also see here the temporal bones, and then you can see some interesting features. The jugular foramina here and here where the jugular veins run, and the carotid canals, which are just posterior and lateral to those openings. Back here, you can see the sphenoid bone, this odd-looking bat-shaped bone here in dark purple. And this, of course, is the vomer, which forms the lower part of the nasal septum, the palatine bones, which form the back third of the hard palate, and, of course, the maxillae, which form the anterior two-thirds of the hard palate and the upper jaw. Here you can see the zygomatic bones as well. The occipital bone, of course, here in sort of light orange. And then if you look very carefully, you can see just a bit more of the maxilla projecting upward beyond this little arch formed by the zygomatic and the temporal bones. Okay, external auditory canal you can see here and here. If we take a sagittal cut through the skull, we can see a few other bones here. Again, occipital, parietal, frontal. This, of course, being the sphenoid, the ethmoid bone here, okay, and then, of course, the vomer down here, this plow-shaped bone. This is mandible. I'm sorry, this is maxilla. This is mandible. You can see the sphenoidal sinus, the frontal sinus, and you can also see the inferior nasal conchae lateral to the vomer and the perpendicular plate of the ethmoid. Other features relevant with the sagittal cut include the spongy bone that lies sandwiched between two layers of compact bone in the flat bones of the skull. Again, this is hematopoietic tissue, but it also serves to lighten the bones of the skull as well as producing greater strength to applied force because of the distribution now of force applied to the compact layers. Again, because this webbing of bone goes every which direction, we distribute the force over a greater surface area. We're less likely to damage the bone itself. So in a sense, it's designed a lot like a football helmet. Your brain, of course, sits inside the cranial vault, and you can see the nasal bones, which form the bridge of the nose. Inferior to the skull is the hyoid bone, which is unique because it does not articulate with any other bone in the body. It's inferior to the mandible, and it's used as an attachment point for neck and tongue muscles. It looks a little bit like a very tiny mandible, but don't confuse it with the mandible. It contains no alveoli, which is where the teeth would sit. The sockets for the teeth are known as the alveoli. Now, prior to birth, our skull looks quite a bit different than it does in the adult. In the infant skull, we don't have fusion of the flat bones yet. We have yet to completely form the synarthrotic joints that hold the cranial vault and the facial bones together. So fontanelles are cartilaginous connections between these flat bones. They represent non-ossified areas that allow the skull to deform as the baby's head passes through the birth canal. Prior or after this happens, it's replaced by bone, and the cranial vault now becomes a much less flexible structure. In point of fact, the entire skeleton begins as hyaline cartilage in the embryonic and fetal stages, and is slowly replaced by ossified bone as blood vessels invade the connective tissue, bringing with them osteoblasts that eventually lay down bone, replacing the cartilage entirely, eventually, with ossified tissue, with the exceptions of the epiphyseal plates and the articular cartilages of the long bones, and areas such as the pubic symphysis at the anterior articulation point of the os coxa, the hip bones, and the intervertebral discs, which we find between the vertebrae. This is the vertebral column. It extends from the skull to the pelvis. It's flexible and sturdy. It provides longitudinal support for the trunk. It's formed by 24 movable vertebrae, a sacrum and a coccyx, and contains intervertebral discs that act as shock absorbers, and they have 4 distinct curvatures. You've got a cervical, a thoracic, and a lumbar curvature, and then in the area of the pelvis and the sacrum, we have this pelvic curvature as well. Okay? Notice that the sacrum and the coccyx are derived from fused vertebrae. This happens again prior to birth. The coccyx is actually the remnant of the embryonic tail, which eventually gets reabsorbed in 99% of births, and it persists only as this vestigial remnant. This is the structure of a vertebra. All vertebrae have common features. They have a neural arch through which the spinal cord passes, sheathed, of course, by the protective membranes, the dura mater, the arachnoid mater, and the pia mater. It's anchored in place by the denticulate ligaments and the filum terminale that prevent vertical and horizontal movement of the vertebral column. It's also cushioned by cerebrospinal fluid inside this foramen as well. So we take special care to protect the brain, the brainstem, and the spinal cord. The spinous processes project posteriorly and inferiorly, so they always are going to indicate the back part of any vertebra. The body are on the anterior portion. The transverse processes project laterally, so you can see some transverse processes here, here, and here. Okay. The superior and inferior articulating processes are areas where the vertebrae articulate with each other, where they form the intervertebral joints. Between the bodies of the vertebrae are the intervertebral discs that also allow for some degree of movement. We call these joints, again, amphiarthroses. That's their functional classification based on their range of motion, which is intermediate between the fully movable diarthrotic joint. Examples include the shoulder and the hip, and the immovable synarthrotic joint as represented by the fusions of the flat bones of the cranium and the facial bones. The intervertebral foramina are openings through which spinal nerves pass. Very important that these not be occluded, as they would damage the spinal nerves and produce numbing and tingling sensations at areas distant from the impingement, and also, in some cases, a lack of function. We call these conditions radiculopathies. The cervical vertebrae support the neck and possess a unique transverse foramina. You can see the transverse foramina here and here. They're important because blood vessels and nerves run through these regions. The vertebral artery and vein run through here, as do major nerves that serve those structures as well. The atlas is the first cervical vertebra, so named because it supports the weight of the skull, as the mythical figure Atlas did the world in Greek mythology. they articulate with the occipital condyles of the occipital bone at the superior articular facets. You can see here and here. Okay, this would be the anterior, and this is the posterior aspect. Again, notice the transverse foramina, and notice in C1 the lack of a body. Okay, so this is one of the unique vertebrae that has no body. It supports the head. Beneath it is the axis. It's cervical vertebrae number 2. It possesses a vertical projection called the odontoid process that allows the nodding of the head no. So it's a pivot point for the axis. It's one of the pivot joints in the body. You can see that in both C1 and C2 we have a forked spinous process. We have the superior articulating facets, and of course the transverse foramina. You can see them also again here, not to as great an extent in the atlas. You can see the remnant here of a spinous process. Okay. Thoracic vertebrae are more substantial because they support more weight. They also articulate with ribs, so that makes them unique. So not only do they articulate superiorly and inferiorly with vertebrae on the top and the bottom, but they articulate laterally with the ribs at the neck and the tubercle and the head of the rib. So the thoracic vertebrae are larger. They have a longer spinous process than the cervical vertebrae. The ribs articulate on the transverse process and on the bodies. And you might say, okay, where? Okay, well, you can see here a facet that articulates with the rib tubercle, and you'll find a small dimple here on the posterior portion of the body of the thoracic vertebrae that articulates with the head of the rib. So the rib itself would project, I can kind of draw it here if I get a chance. It's going to project here. Let's do this in blue. If I were to draw a rib, okay, it would look, let's see here, look like this. So it would project back and back and back, and then it would wrap all the way around to the front, like so. Okay, and articulate either with cartilage that directly articulates with the sternum, or with cartilage that articulates with cartilage that articulates with the sternum. And again, notice the vertebral foramen. Okay, so how the ribs touch the thoracic vertebrae, very important. The lumbar vertebrae lie below the thoracic vertebrae. They have heavy, thick bodies that support much more weight. As a result, they're more substantial. They have larger processes for the attachment of back muscles, and they do not have articulation points with ribs because the ribs end again at the end of the thoracic division. The sacrum lies below the lumbar vertebrae. It's 5 fused bones that form the posterior wall of the pelvic girdle, while the coccyx lies inferior to it, forming the tailbone, and consists from between 3 and 5 fused rudimentary vertebrae, depending on the individual. Interesting thing to note, again, the sacrum is relatively smooth in the front. You can see where the vertebrae fused here. Okay, there are no intervertebral discs in the sacrum. And then on posterior aspect, you see the median sacral crest and the coccyx, and again the posterior foramina. Okay, again, nerves radiate through this region. The lumbar vertebrae would be up here, and the coxal bones would be lateral here and here, forming the sacroiliac joint. The thoracic cage is composed of the thoracic vertebrae, which contain the ribs, and the costal cartilages and the sternum. It's important for protecting our heart and our lungs, and it also supports the upper body. Notice while we're here that the ribs come in several forms. The true ribs have direct attachments via cartilage to some portion of the sternum. There are 7 of those, and you can see them numbered here, 1 through 7. Okay. Below them are the false ribs, numbered 8 through 10. They're called false ribs because they connect to cartilage, which in turn connects to cartilage, which connects to the sternum. And then the last 2 are the floating ribs, which have no anterior connection whatsoever. As a result, They can be easily damaged with a blow to that region. You can knock a floating rib free. It has the potential to puncture an organ. Notice that the sternum forms the anterior articulating point of the rib cage, and the sternum has three parts. The upper manubrium, which articulates again with the first true rib and portions of the second true rib, the body here, the long portion, and the xiphoid process, this terminal portion down here. The xiphoid process is a major anatomical landmark. It's used by people that administer CPR as a way to massage the heart in the event that it stops. Okay? So very important to know where that's located. So those are the functions and the features of those different bones. We should point out also that the sternum is held together by synarthrotic joints. Okay, the sternum does not, as a bone, move, but the attachments between the costal cartilages of the ribs and the sternum do permit the movements that are associated with acts such as breathing. Okay. The appendicular skeleton consists of the arms of the bones and legs, as well as the pectoral and pelvic girdle. The pectoral girdle is formed again by the scapula and also portions of the clavicle, while the pelvic girdle is formed entirely as a result of the os coxa, the coxal bones of the hip. There are 126 individual bones in the appendicular skeleton, but the bulk of them lie in the hands and in the feet. So the pectoral girdle, you can see here, again, composed of two clavicles, two scapulae. The clavicle articulates with the sternum and the scapula at a very special joint, the clavicular acromial joint, you can see here, okay, and the coracoid process, which forms the anterior bony margin of the shoulder joint. Okay, that's also a portion of the scapula. Notice with our view of the pectoral girdle that the scapula is smooth on the anterior aspect while it has bony protrusions on the posterior aspect. The reason again is to allow the scapula to move against the rib cage when you perform actions such as moving the arms, raising the shoulders, and so forth. If it had a rough surface, this movement would be impeded. The scapula is located on each side of the vertebral column, and it's held in place by muscles that allow free shoulder movement. And again, you can see here posterior view of the scapula, some major features we need to point out. This is the spine of the scapula, this ridge along here. It terminates in the acromion process. The coracoid process is this crow-shaped projection that's on the front of the scapula, and the glenoid fossa articulates directly with the proximal head of the humerus. There are some indentations we should know. This is the supraspinous fossa. Fossa means indentation. The infraspinous fossa. And then on the anterior portion of the scapula here, the subscapular fossa. And as we're going to find out when we get to the skeletal muscle, there are muscles that are named for those attachment points that help to stabilize the shoulder while you move the arm. The major bone of the upper arm is the humerus. It articulates with the scapula at the shoulder and the ulna at the radius and the elbow. You can see that the front and the back look quite different. On the front, you do not see a groove running down the shaft, and you're also able to see the olecranon fossa. Okay, so you can see here the front and the back of the bone relatively easily. I want to make sure that I've got you right here. My apologies. This is the posterior aspect of the humerus. This is the anterior aspect. How can you tell the difference? Okay, the olecranon fossa is a deeper indentation than the corresponding indentation on the front of the humerus, the coronoid fossa. The olecranon of the ulna fits into this little divot, and this is what forms the point of the elbow. The capitulum and the trochlea are articulation points for the radius and the ulna, and they permit movement at the elbow joint in one axis. You don't see the greater or lesser tubercle on the back of the humerus. You do see a little bit of the deltoid tuberosity and portions, of course, of the proximal head. Two other features we should note: the surgical neck, which marks the division between the anatomical proximal head and the epiphysis, and the surgical neck, which is approximately where the epiphyseal plate would occur. Okay, so two different necks that we need to note between the head and the rest of the bone, and between the epiphysis and the diaphysis, which is here. On the anterior aspect of the humerus, we can see the greater and lesser tubercle, the intertubercular groove through which the tendon of the biceps brachii runs, the deltoid tuberosity, which is an attachment for the deltoid muscle, that triangular muscle on the upper part of your shoulder that allows you to flap your arms as if you're flapping your wings. And then down at the distal epiphysis, you can see the coronoid fossa, which is where the coronoid process, which forms the pit on the front of the elbow, fits. You can see here also the capitulum and the trochlea, as you could on the back side, and then you've got the medial and the lateral epicondyles. Lateral epicondyle obviously on the lateral side of the distal head of the bone, and the medial epicondyle on the medial side. Now, this bone articulates proximally and medially with the scapula, and to some extent with the clavicle, and it articulates distally with the radius and the ulna. So let's take a look at the radius and the ulna. The ulna is the bone that's on the little finger side of the forearm in anatomical position. It does not move when the hand rotates, while the radius is the lateral bone in the forearm that crosses over the ulna when you pronate, when you change the position of your hand from palm facing forward to the dorsum, the back of the hand facing forward. You can see here a few important features. At the proximal end of the ulna, you have a U-shaped structure that consists of the olecranon process, the trochlear notch, and the coronoid process. The way I was always taught to remember this is to remember the mnemonic OTC, which stands for over the counter. Okay, so let's draw that here. O T C, over the counter, for the features of the proximal head of the ulna. Okay, proximal head of the radius is very unusual because it is perfectly dime-shaped. No other bone in the body has that. And on its medial side, it has radial tuberosity. The proximal head of the radius sits in the radial notch of the ulna to allow that rotating movement. And then you can see at the distal head of the radius the styloid process, which forms the bump on the outer side of your wrist. And also, while we're here, the distal head of the ulna contains a styloid process which forms the bump on the little finger side of your wrist. Okay, styloid means needle-shaped. We move on here to the bones of the hand. The bones of the wrist are called the carpal bones. The bones of the palm of the hand, the metacarpals, and the bones of the fingers as the phalanges. Okay. Again, we're not going to memorize each individual carpal bone. Just know that when we look at these bones here, these are the carpals. Okay, those are the carpals right here. All right, the metacarpals here. And the phalanges, the remaining bones here. Notice that in the second, third, fourth, and fifth digits, there is a distal, a proximal, and a middle phalanx. Okay, while in the thumb there is only a proximal and a distal phalanx. This is termed digit 1. Okay, so the thumb is the first digit, then the index finger, the middle finger, the ring finger, and of course the little finger. Okay. At first glance, I'm going to say that we are looking at the back of the hand here for a couple reasons. I don't see the characteristic projections on the carpal bones that I would expect to see on the anterior aspect, so I think we're looking here at the back of the hand. But again, you're not going to have to concern yourself with individual carpal bones. Okay, we're just going to deal here with the 3 divisions. The joints between the carpal bones are sliding joints. Okay, sliding or gliding joints. The joints between the metacarpals and the phalanges are amphiarthrotic hinge joints, and between the metacarpals and the carpals we also have hinge joints as well. The articulation between the metacarpal of the first digit and the carpal bones of the wrist is a unique joint called a saddle joint, which allows for the movement of opposition, where you're able to take your thumb and touch the tips of your remaining fingers. The reason that that's a big deal is because that allows you to write, to paint, to use tools. So this is a major step forward in evolution. This allowed us language and culture and the use of tools. So you could think of that joint as primary to the building of civilization. The pelvic girdle consists of 2 coxal bones, the sacrum, which forms a rigid bony pelvis, and the coxal bones, which articulate with it laterally. This area here is the sacroiliac joint. There's one there and there's one there, and this articulation in the front is known as the pubic symphysis. The lumbar vertebrae are superior to the sacrum, while the coccyx is inferior to it. The acetabulum is the point of articulation for the proximal head of the femur, forms the hip joint, one of the 2 most movable joints in the body, the other one being the shoulder joint. The reason for this is that they are ball and socket joints. They're a special kind of diarthrotic joint that allows movement in all axes, so that makes them relatively unique. The coxal bones have 3 parts to them. The fan-shaped area up here is called the ilium. Okay? The portion in the front down here is called the pubis, and the part that you sit on is known as the ischium. Okay, so ilium, ischium, pubis. The pelvic girdle in men and women is quite different. And the reason for this is that the pelvic girdle for the female is designed for birth. As a result, the angle of the pubic arch is much wider, and the pubic inlet and outlet are much wider as well to allow passage for the baby's head through the birth canal. In the male pelvis, you can see that we have a much narrower pubic arch, and the pelvic inlet and outlet are much, much tinier. Okay, so very important that we understand the difference between the 2 sexes, right? Again, another example of form following function. The reason that something has a particular shape is because it has a particular job to do. Now, if we were to look at the pelvic bones from the lateral and medial aspect, they would form from 3 different fused bones, the ilium, the ischium, and the pubis. Okay? These are attachment sites for the bones of the lower limbs, and they articulate at anterior midline at the pubic symphysis, which is an amphiarthrotic joint whose flexibility allows for childbirth. You can see here from the lateral aspect, this is the acetabulum, this is the socket where the proximal head of the femur sits, and you can see the crest-shaped ilium up top, the greater and lesser sciatic notches, and the ischial spine here on the ischium. The ischium is the portion of the coxal bone that you sit on, and of course the portion that's at anterior midline is the pubis. It forms the medial portion of the obturator foramen, medial and portions of the superior portion of the obturator foramen, this little opening here. Okay. From medial aspect, you can see the articulation point for the sacroiliac joint here with the sacrum, and you can also pick up again the ilium, the ischium, and the pubis in the front. Okay. This area here is called the anterior superior iliac spine. This is the iliac crest, and then the posterior superior iliac spine would be this area in the back. Okay. The significance of the greater and lesser sciatic notch is that the sciatic nerve runs through this region. The sciatic nerve is one of the thickest nerves in the body and the most easily impinged. It's often damaged or impinged in childbirth and in people that have trouble controlling their body weight. The lower extremity is made up of the femur, the major bone of the upper leg. It's the largest and strongest bone in the body. The patella, which is your kneecap, it is a sesamoid bone in a tendon that extends anterior to the knee. And you can see here the front and the back of the femur. Again, you can tell the front of the femur because it's relatively smooth and it tends to be convex. The back of the femur is relatively rough and tends to be concave. Looking at the front of the femur, you can again see the proximal head and the greater and the lesser trochanter, which are processes to which hip bones or hip muscles attach. And then you can see, of course, the distal head. This is the articulating surface for the patella. And then from the back portion, you can see the greater and lesser trochanter, the head, and then this little ridge down the back, which is called the linea aspera. Okay. At the bottom, you can see the lateral and the medial condyles. These are articulation points for the tibia. Okay. We're going to find out there's another bone in the lower leg called the fibula, and the femur does not articulate with that bone. Okay, the tibia is your shin bone. It's the larger of the lower leg bones and bears the body's weight, while the fibula is the lateral strut of your lower leg and is a lateral stabilizer. It is a much slenderer bone. Again, the proximal head of the tibia is characterized by the presence of the tibial tuberosity, which is an attachment point for the patellar tendon, and the lateral and medial condyles, which articulate with the condyles of the femur, forming the knee joint. The medial malleolus forms the inner bump of your ankle, and the lateral malleolus, which is present again on the fibula, forms the lateral bump on your ankle. You can see the head of the fibula does not extend all the way up to the femur, but it does articulate at its distal end along with the distal head of the tibia with the tarsal bones, the bones of the ankles, particularly the talus and some of the other selected tarsal bones. Okay, the tarsals are your ankle bones, while the metatarsals are the bones of the sole of your foot, while the phalanges are the bones of your toes. So we can see here the tibia, the fibula, the talus, of course, which articulates with both of these, the calcaneus, which is your heel bone, and then we can see the bones of the sole of your foot, which are your metatarsals, and the bones of your toes, which are also your phalanges, just as the bones of your fingers and thumbs. And again, notice some homology between the toes and the fingers. The phalanx of the big toe has only a proximal and a distal part, just as the thumb only has a proximal and distal phalanx, while the bones of the toes have a proximal, medial, and a distal phalanx. The distal phalanx is, of course, the tip of the toe, the proximal phalanx articulating with the metatarsal bones. Okay, a way to tell the top from the bottom of the talus, if you're ever confused, the top of the talus is very smooth, and it's going to articulate with the tibia and the fibula. The calcaneus is a relatively rough bone and serves as an attachment point for the calcaneal tendon, which allows you to point your toe directed under the action of the soleus and the gastrocnemius muscles. Articulations are joints areas where two bones come together, and they're characterized both by their structural components and by their functional classification. They allow for varying degrees of movement. Immovable joints are synarthroses, slightly movable joints known as amphiarthroses, and freely movable joints, which we call diarthroses. So in synarthrotic joints, they're tightly separated by thin fibrous connective tissue. There's no movement. Examples include the sutures that we see in the sternum and in the facial bones and the cranial bones of the skull. Slightly movable joints are separated by a layer of cartilage or fibrous connective tissue. They show limited flexibility. Examples include joints between the vertebrae. Freely movable joints are characterized by the presence of a joint capsule, articular cartilage, and synovial fluid. We call these diarthrotic joints because they have the greatest range of motion. They're structurally more complex than the other joints. There are several types of these joints. We're seeing here a cross-section through a diarthrotic joint. You can see here the distal head of one bone articulating with the proximal head of the other, the articular cartilage here in green, the synovial fluid, the blue fluid that fills the joint capsule, and of course the connective tissue membrane that forms the joint capsule, bordered and on its deep margin by synoviocytes, which secrete the synovial fluid, which provides lubrication for the diarthrotic joint and also nourishment for the articular cartilage, and on its superficial side by fibrous connective tissue. Gliding joints involve the sliding of bones across each other. Examples include the tarsal and the carpal bones articulating with themselves, while condyloid joints allow for movement from side to side and back and forth. Examples include the carpals and the bones of the forearm. Hinge joints allow movement in one direction only. Examples include the knee and the elbow joint. The knee joint is pictured here. You can see the distal head of the femur articulating with the proximal head of the tibia, and then inside the joint you can see the synovial fluid. You can see portions of the meniscus, which is fibrocartilage that allows a better fit between the two heads of these bones. You can see it projecting here into the joint cavity. On the anterior aspect, you can see the patella and of course its articulating cartilage, and you've got fat pads, and in addition, not shown really that well here, are intra and extracapsular joints that stabilize the joint so that it only moves in one direction. In the knee, the intercapsular joints include the anterior and posterior cruciate ligaments, while the extracapsular joints include the medial and lateral collateral ligaments. The point of these ligaments is so that the knee only bends in the way that you would expect your knee to bend when you walk. Okay, you're able to flex the knee. The knee is not meant to hyperextend. Okay, which would be bending essentially in. I'll show you which direction here. This direction would be hyperextension, and this direction would be flexion. Okay, while bringing it back to midline would be extension. So you can flex and extend the knee, but you cannot hyperextend the knee unless you damage it tremendously. Okay, there are also fluid-filled sacs that lubricate the ligaments and tendons around the joint. We call these bursa. They have almost a ball-bearing action on the joint, and they cut down again on inflammation associated with movement. Saddle joints are at the ends of bones that are saddle-shaped. There's only one saddle joint in the body, and that's between the metacarpal bone of the first digit and the carpal bones. They provide movement side to side and back and forth, but the trapezium and the metacarpal of the thumb are the only saddle joints in the body. Pivot joints allow rotational movement. Examples include the atlas on the axis that allows you to shake your head no. Okay, There are other pivot joints as well. Ball and socket joints are a rounded head of one bone fitting into the concavity of another bone. They provide the greatest degree of movement and as a result are the most easily injured. Movement may be rotational or in any plane. Examples include the hip and the shoulder joint, and you can see here a cross section through these joints and some of the major features. Okay, this would be the acetabulum of the coxal bone. This is the proximal head of the femur. You can see the joint capsule and the articulating cartilages, and you can see also again the stabilizing ligaments and tendons. So, what kind of movements are permitted at freely movable joints? Movement is caused by contraction of muscles that span the joint, and it depends upon the joint type and the location of the muscle that's involved. So you can see some examples of movement here. Adduction is movement back towards midline, while adduction is movement away from midline. Flexion and extension. Flexion is to reduce the angle between two body parts in anatomical position, while extension is to increase the angle between two body parts in anatomical position. Inversion and eversion, you can see this here with the foot. Eversion is to turn the sole of the foot inward towards midline, while inversion is to turn the sole of the foot, inversion is to turn the sole of the foot inward towards midline, while eversion is to turn the sole of the foot outwards away from midline. Dorsiflexion and plantar flexion are opposites of each other. Dorsiflexion is to lift the toes, while plantar flexion is to point the toes. Again, they get their names from the dorsum, which is the top of the foot, and the plantar surface, which is the bottom of the foot. Some other movements you can see include hyperextension, extension, and flexion. In anatomical position, we're permitted these movements at the shoulder and at the wrist and at the neck, okay, and at the hip, okay. Other movements include supination and pronation. In pronation, we turn the back of the hand towards the anterior. In supination, we turn the palm of the hand towards the anterior. Elevation and depression. Elevation to raise in the superior direction, such as elevating the shoulders. Depression is to drop in the inferior direction, such as dropping the shoulders. Protraction and retraction. Protraction is to jut a body part in the anterior direction, and retraction is to pull a body part in the posterior direction. You can do this, for instance, with the jaw, okay? And then the last thing that we want to touch on are disorders of the skeletal system. They can be characterized as disorders of the bones or joints. Orthopedics is the branch of medicine that specializes in treating skeletal disease and abnormalities. So let's start with abnormalities of trauma. Fractures are broken bones. In a complete fracture, the break is completely through the bone. A compound fracture causes the bone to pierce the skin. A simple fracture is where the bone does not pierce the skin. Comminuted fracture is where the bone is broken into several pieces, while a segmental fracture, only one piece is broken out of the bone, and in a spiral fracture, the fracture line spirals around the bone. An oblique fracture is a break at angles across the bone, while a transverse fracture is a break at right angles to the long axis of the bone, while an incomplete fracture, the bone is not broken completely through. A green stick fracture is where the break is on one side of the bone and the bone is bowed, while a fissured fracture, the break is a lengthwise split in the bone. You can see examples of these fractures here, and stay tuned for a video that details some different types of fractures.
The skeletal system is made up of 206 bones and provides support, allows for movement, and protects the internal organs of the body. Sometimes too much pressure is applied to a bone that results in what is known as a fracture. Fractures are often classified as either open or closed. An open fracture is a fracture where a piece of the broken bone pierces through the skin. This can be dangerous because the bone is exposed, increasing the risk of infection. A closed fracture is a fracture where the bone is broken but does not come through the skin. A compression fracture is a closed fracture that occurs when two or more bones are forced against each other. It commonly occurs to bones of the spine and may be caused by falling into a standing or sitting position or a result of advanced osteoporosis. An avulsion fracture is a closed fracture where a piece of bone is broken off by a sudden forceful contraction of a muscle. This type of fracture is common in young athletes and can occur when muscles are not properly stretched before activity. This fracture can also be a result of an injury. An impacted fracture is similar to a compression fracture, yet it occurs within the same bone. It is a closed fracture that occurs when pressure is applied to both ends of the bone, causing it to split into two fragments that jam into each other. This type of fracture is common in falls and car accidents. All fractures must be taken seriously. If you think that a bone has been fractured, you should seek immediate medical attention.
Okay, other bone disorders include osteomyelitis, which is an inflammation of the bone and the marrow because of bacterial infection, osteoporosis, which is a softening of the bone due to loss of calcium salts leading to easy fracture and crushing. It's common in older people and in postmenopausal women, often due to lack of estrogen. It's also exacerbated by inactivity or a sedentary lifestyle. Rickets is a childhood disease due to a deficiency of calcium salts in the bone or a dietary deficiency in calcium or vitamin D. The children have a bow-legged appearance in this disorder. Arthritis is characterized by inflammation, swelling, and pain. It's a general term for inflammation of the joint, and it comes in several flavors. Rheumatoid arthritis is an autoimmune disorder where the immune system attacks joint tissue, causing it to swell and inflame. Often the joint can ossify, making it immovable. Osteoarthritis is the wear and tear that results as the articular cartilage of diarthritic joints wears down, resulting in bone on bone, which produces bone spurs, which irritates and inflames the joint. Bursitis is an inflammation of the bursa. The bursa, again, are the fluid-filled sacs that lubricate tendons and ligaments around the joint, easing movement, while dislocation is displacement of bones that form the joint. A herniated disc is an intervertebral disc that protrudes beyond the vertebrae and can impinge the spinal cord. It's often caused by improper lifting technique that results in excessive pressure, and the danger, of course, is that you can damage the spinal cord or even, in some cases, crush it. Other disorders of the joints include spinal curvature, such as kyphosis, which is an extreme thoracic curvature often seen in osteoporotic individuals, lordosis or swayback, which is an excessive lumbar curvature. This generally results from individuals who've gained a lot of weight or who are pregnant as they thrust their abdomen forward to maintain balance. And then scoliosis, which is a lateral curvature often due to having lower limbs of unequal length or having problems related to the ligaments and tendons that stabilize the spine in the lateral aspect. A sprain is a tearing or stretching of ligaments and tendons without dislocation. Strain and sprain are kind of related to each other. In strain, we tend to damage tendons, and in sprain, we tend to damage ligaments. Okay, there's a slight distinction there. When you damage the ligament, we have a problem frequently with healing because of the low blood supply to ligament. It takes much longer to heal than tendon does and the result can be a much more protracted recovery. Whereas in a tendon, there's at least a modicum of blood supply, and as a result, the healing process is considerably faster. Okay, stay tuned for a couple of videos on the skeletal system, one dealing with the skull, and then one dealing with the anatomy of the skeletal system. And then I will join you for your next podcast, in which we'll cover the material in Chapter 7. Okay, thank you for being with me today, and I wish you all a good evening.
1. The skeletal system.
Now that you've learned a few basic anatomical terms, you're prepared to boldly explore one of the most important bodily systems, the durable, yet unexpectedly sensitive, skeletal system.
The skeletal system is a vast and a complex system that is home to more than 206 bones as well as cartilage. Cartilage is the bendable stuff found at the end of your nose, among other places. This bone and cartilage combo makes up 20% of the total mass of the human body.
The skeletal system is designed to protect and support. That's its job, and it does it well.
The skeletal system as a whole can be broken down into two major divisions, the axial division and the appendicular division. The first part we'll look at is the axial division.
Section A, the mighty axial skeleton.
And now, an amusing fact from everybody's favorite anatomical educator, Slim Goodbody.
Did you know that the word skeleton comes from a Greek word meaning dried up body? Dried up bodies are fun!
The axial skeleton is composed of 80 bones and forms the long axis of the body that we mentioned before. This includes three major regions: the skull, the vertebral column, and the bony thorax.
Now, the axial division has an important job, namely supporting the head, neck, and torso, as well as protecting the brain, spinal cord, heart, and lungs. Without it, we'd be a gelatinous lump, unable to protect ourselves.
All right, maybe that's not true, but I'll tell you what is true. The skull is the most complex part of the axial skeleton, and also what we're looking at first. But before we do, it's probably a good idea for you to learn a few anatomical terms to help you understand the descriptions of bones in the axial skeleton. Two important terms to know are the terms paired and articulates.
The term paired usually means that a bone is paired with a copy of itself. In poker, you can have a pair of aces. In the skeletal system, you can have a pair of bones. For example, the temporal bones, two bones that help make up the sides of your skull, are paired bones. Obviously, the opposite of paired is unpaired. That's a bone that doesn't have a match.
The phrase articulates with is another way of saying connects with. So, for example, the radius and the ulna are two bones in your forearm that we'll talk about later. Both of these bones are connected to the humerus, a bone in your arm. So both the radius and the ulna articulate with the humerus.
So, if one bone articulates with another bone, it's connected to it. Got it?
Ask me in an hour.
Will do. Let's move on to the skull.
Region 1, the skull.
The skull is made up of 22 different bones, not including the 3 tiny bones in each ear. The bones of the skull are divided into 2 sets, the cranial bones, or the bones of the cranium, and the facial bones.
The bones in the cranium.
The cranium is unbelievably important because it protects the ears and the brain like a bony helmet. It also serves as a point of attachment for muscles in the head that we'll discuss later.
The cranium contains 8 bones. 2 of them are paired and 4 of them unpaired. The 2 paired bones are the parietal and the temporal. That's 4 bones total. The 4 swing-in single bones are the frontal bone, the occipital bone, the ethmoid bone, and the sphenoid bone.
Altogether, that's 8 bones, and yes, you have to know them all. Thus, the memorization begins.
The frontal bone is the bone that forms the forehead and part of the eye sockets, or as smart people say, the superior orbits. The frontal bone also contains the paranasal sinuses, the mucus-lined cavities that warm up and filter air as we breathe it. If you're confused, don't worry. We'll give you more detail on the sinuses a little later on.
The paired parietal bones form the upper sides, or simply put, the roof of your cranium. The occipital bone forms the posterior base of the skull, at the back of your head. And let's not forget the paired temporal bones. These bones form the inferior lateral sides of the skull at your temples, just over your ears and below the parietal bones. Remember, inferior means lower, and lateral means outer side of. So the temporal form the lower, outer side of your cranium.
There are also two bones found at the anterior base of the cranium. These are the ethmoid bone and the sphenoid bone.
The ethmoid bone helps form the nasal cavity and the nasal septum, a wall that separates the cavity into right and left sides.
Don't worry, we'll go into more detail on the nasal cavity in a little bit.
The sphenoid bone is located at the anterior or front part of the cranium's base. The sphenoid bone articulates or connects with all other cranial bones. Because of this, the sphenoid bone is sometimes called the keystone of the cranium.
One way to help remember the names of these bones is by breaking them up into ols and oids. The oid bones, ethmoid and sphenoid, are internal bones of the cranium. The ol bones, frontal, parietal, occipital, temporal, are all external cranial bones. Get it?
Yeah, time for nakedness. Woo!
Sorry, nakedness will have to wait until we finish talking about facial bones.
There are 14 beautiful, beautiful facial bones. 6 of them are paired and 2 of them are unpaired, for a grand total of 14 facial bones.
The facial bones are the unpaired mandible, the paired maxillae, the paired zygomatic bones, the paired nasal bones, the paired lacrimal bones, the paired palatine bones, the paired inferior nasal conchae, and the unpaired vomer.
These wonderful bones are directly connected to the facial muscles, which we'll talk about later. Those fantabulous facial bones also provide cavities for the facial organs, like the eyes, nose, and tongue. But it doesn't stop there. The facial bones also anchor the teeth and even serve as pathways for air and food.
One of the most important facial bones is the mandible. The mandible forms the lower jaw and anchors the bottom teeth. It's the largest and strongest of all the facial bones.
Now, it's true the mandible is strong and works well for George Clooney and Jay Leno, but the paired maxillae are important facial bones.
The paired maxillae anchor the upper teeth and form the upper jaw. They also form the anterior or front part of the hard palate. In everyday life, the hard palate is known as the roof of the mouth, but it doesn't stop there. The paired maxillae also form the inferior orbits. That's the lower part of the eye sockets. They even help form the nasal cavity.
Other important facial bones are the paired zygomatic bones. These bones are the ones that form the cheekbones. Then there's the paired nasal bones. Without these babies, there'd be no bridge to your nose. And let's not forget the paired lacrimal bones. The lacrimal bones form the anterior medial orbits, which are part of the eye socket and, sadly enough, contain the lacrimal, or tear sacs.
Another important pair of facial bones are the palatine bones. You remember earlier when we said that the paired maxilla make up the hard palate? Well, they don't do it alone.
The paired palatine bones make up the posterior hard palate. That's the back part of the palate. The paired palatine bones also make up a small part of the floor of the orbits, or eye sockets. And finally, they help make up our friend the nasal cavity. That's inside your nose in case you've forgotten.
And then there's the unpaired vomer, yet another important facial bone.
The vomer forms the posterior and inferior parts of the nasal septum. That's the back lower part of the little wall that divides the inside of your nose.
Finally, there's the paired inferior or lower nasal conchae. The paired nasal conchae make up the lateral or side walls of the nasal cavities. You got it? Now might be a good time to rewind the tape and review what you've just learned.
Oh, right, the hyoid bone. There's also a hyoid bone, which isn't officially part of the skull, but is often discussed at the same time.
The hyoid bone is a small horseshoe-shaped bone. It's located inferior to, or below, the mandible, and it's superior to the larynx, or voice box, in the anterior neck. Whew, that was a mouthful. The hyoid bone serves as a point of attachment for a bunch of neck and tongue muscles. It also acts as a movable base for the tongue.
The hyoid bone is a unique, almost sad bone. It's the only bone that doesn't connect directly with any other bone in the body.
Region 2, the vertebral column.
The vertebral column, or as it is known in dumb guy circles, the spine, consists of 26 different bones called vertebrae. The vertebrae are separated by pads of fibrous cartilage called intervertebral discs, which absorb pressure and allow for maximum flexibility. The vertebrae are held together and stabilized by types of connective tissue called ligaments and tendons. Ligaments attach bones to bones, and tendons attach bones to muscles. But don't worry, we'll elaborate on tendons and ligaments in a bit. The vertebral column houses and protects the spinal cord, another structure we'll give you the details on later.
And now, another amusing fact from the man with the anatomical plan, Slim Goodbody.
Did you know that the adult spine is 28 inches long, and if ripped out, can be played like a glockenspiel? Glockenspiels are fun!
The vertebral column is separated into 5 different divisions. They are the cervical division, the thoracic division, the lumbar division, the sacral division, and the coccygeal division.
The cervical division contains 7 small vertebrae which are located in the neck. The thoracic division contains 12 vertebrae which are located in the torso. These vertebrae articulate or connect with the ribs. The lumbar division contains 5 vertebrae which are located in the lower back.
To remember the number of vertebrae in these first 3 sections, think of the times most normal people eat breakfast, lunch, and dinner, 7 a.m., noon, and 5 p.m. Think of the cervical division as the breakfast division, with 7 vertebrae. The thoracic is lunch, with 12, and the lumbar is dinner, with 5 vertebrae. Pretty helpful, huh?
Okay, the sacral division, or the sacrum, contains 5 vertebrae. These vertebrae are fused or melded together into one big vertebrae in adults. It's inferior to or below the lumbar vertebrae. The coccyx, located inferior to the sacrum, contains 3 fused vertebrae. It is sometimes called the tailbone.
The vertebral column also contains 4 curvatures, which give it an S shape and a super spring-like flexibility.
The top curvature in the vertebral column is called the cervical curvature. This curvature is concave posteriorly, meaning it caves inward like a spoon. It is located in what we call the neck. The thoracic curvature is convex posteriorly, meaning it bulges outward like an eyeglass lens. This curvature is located in the upper backbone. The lumbar curvature is also concave posteriorly, but this curve isn't formed until we begin to walk upright. This curvature marks the lower backbone. And finally, the sacral curvature is convex posteriorly.
These curvatures give our spines an attractive S shape that men and women adore both at home and abroad. But as with all things good, curvatures have a downside, namely curvature abnormalities.
Curvature abnormalities can be blamed on any number of factors. Some are congenital, which means they were present before birth. Some are even caused by bad posture. There are a few common curvature abnormalities, like scoliosis, kyphosis, and lordosis.
Scoliosis, for instance, is an abnormal curvature that usually occurs in the thoracic region of the spine. That's the second region that forms the upper backbone. For some unknown reason, scoliosis is more common in girls and can sometimes be caused by having lower limbs of unequal length. Scoliosis can sometimes be treated surgically or with a body brace. Kyphosis is an extreme thoracic curvature, creating a condition known as hunchback and inspiring lackluster animated films. You can get this disease from rickets and tuberculosis of the spine. Lordosis is an extreme lumbar curvature and is commonly referred to as swayback. Lordosis sometimes affects pregnant women and individuals with potbellies. This is because people with potbellies have a tendency to thrust their abdomens forward.
Well, that's the vertebral column and all of its trappings. We've also discussed the skull. That leads us to the final part of the axial skeleton, the bony thorax. Now, the bony thorax may sound like a mythological...
I am the bony thorax. Beware the vengeance of the false ribs. You must
You're
go
not the bony thorax. You're just a guy in a cloak.
Am I? Or is your mind numb with fear?
Well, don't I feel foolish?
Region 3, the bony thorax.
The bony thorax, or the thoracic rib cage, protects the heart and the lungs. It serves as a point of attachment for the neck, head, back, chest, and shoulder muscles. The bony thorax is made up of 3 parts. They are the 12 thoracic vertebrae, the sternum, and the ribs.
The thoracic vertebrae form the posterior midline of the rib cage. That means they divide the rib cage in half from the backside. The sternum, or the breastbone, forms the anterior midline of the cage. It's easy to find the sternum. It's the hard plate right in the middle of your chest. And finally, the ribs are 12 paired flat bones that form the lateral or sidebars of the cage. That means altogether there's 24 ribs. The ribs are all directly attached to the thoracic vertebrae, but not the sternum.
The first 7 ribs are called the true ribs. The true ribs are attached anteriorly to the sternum by hyaline cartilage, a special type of cartilage, and they are, of course, as stalwart and honest as Abe Lincoln. The last 5 ribs are known as false ribs. The false ribs are indirectly attached to the sternum by cartilage located directly above them. They are also as wily and dishonest as the pickpockets from the musical Oliver. The last 2 false ribs are sometimes called floating ribs because they have no attachment, physical or emotional, to the sternum. Instead, they are attached to muscles in the lateral wall of the body.
And remember, the ribs are paired bones, so there's 24 altogether.
Well, that about sums it up for all 3 parts of the axial skeleton: the skull, vertebral column, and the bony thorax. And if you can't remember all the names and characteristics of the bones we've discussed, feel free to fail your test. Oh, I'm sorry. I didn't mean to say that. Feel free to rewind the tape and review at your own pace. But brace yourself, because there's more to the skeletal system than just the axial skeleton. Prepare to confront and conquer the appendicular skeleton.
Section B, the appendicular skeleton.
While the axial skeleton protects the brain, heart and lungs, and spinal cord, the appendicular skeleton helps us move. The appendicular skeleton is made up of the upper and lower limbs. We usually call them arms and legs. It's also made up of the girdles of these limbs. The girdles attach the limbs to the axial skeleton. All the bones in the appendicular skeleton help us move and allow us to manipulate our environment.
Also, bear in mind that when we're talking about the appendicular skeleton, we're talking about duplicates. The bones of the legs, arms, girdles all have duplicates on the other side of the body. This is known as bilateral symmetry.
Region 1, upper limbs.
One of the many important bones contained in the appendicular skeleton is the pectoral girdle. The pectoral girdle is also called the shoulder girdle. So remember, even though we're only describing one pectoral girdle, there are 2 in your body because you have 2 shoulders.
The pectoral girdle attaches the upper limb to the trunk of the body and also anchors muscles that move the limb. Each girdle is made up of 2 bones, the clavicle and the scapula. The clavicle, or collarbone, is the anterior bone. The scapula, or shoulder blade, is the posterior bone.
You have 30 bones in each upper limb, each one of them useful, each one of them special in its own way. Why, without the 27 bones of your hand, you'd never be able to play an exciting game of skee-ball. And without the humerus, the radius, and the ulna, you'd never be able to carry home those exciting prizes you won playing skee-ball. Exciting prizes like whoopee cushions and decorative magnets.
I don't play skee-ball.
Well, you should. It's exciting, but not half as exciting as an in-depth discussion of the bones in our upper limbs.
As we said before, each of your upper limbs contains 30 bones, broken down into 3 parts: the arm, the forearm, and the hand. And these 3 regions can be broken down into individual bones. So let us now take advantage of the knowledge and experience of our elders as we turn to the Old Person's Learning Annex to learn about bones in the upper limbs.
It's the Old Person's Learning Annex, where we learn from the wisdom of our elders.
They say that the upper arm contains 1 bone, the humerus. It is the largest and longest bone in the upper limbs. Well, I will tell you, I do not find a lot of humor in this bone. It is not a funny bone. It is not funny at all. You see, the knee, that is a funny bone. You get hit in the knee, and it goes, ugh, and you go, oi, and you kick, and it's a funny thing.
The upper arm contains only a single bone, the humerus, whereas the forearm contains the radius and the ulna. The proximal ends of the radius and ulna, that's the ends closer to the trunk of the body, those ends connect with the humerus to form the elbow. Their distal ends, you know, the ends further from the trunk, they connect with the hand to form the wrist.
And now, the Old Person's Learning Annex, where long-winded stories serve us well.
I remember when my son Herb broke all 27 bones in his hand. I remember it like it was yesterday. He was 4. He's 32 now, and he's an accountant. He's so very, very good. Herb was out playing carpenter with his cousin Murray. Anyway, Murray, being the cute little idiot that he is, he took a ball-peen hammer and smashed Herb's hand. That's right. He broke all 8 carpals, all 5 metacarpals. Those are the 5 long bones that form the palm, and he broke all 14 phalanges. That's the fingers in the thumb.
So the hand is made up of 8 carpals, 5 metacarpals, and 14 phalanges. The 8 carpals are the bones that form the wrist, where we put our watches and bracelets. The 5 metacarpals make up the palm, and the 14 phalanges give us our fingers and a pollex, which is a fancy word for thumb.
There's the shoulder girdle made up of the clavicle and scapula. And then there's the humerus, ulna, radius, 8 carpals, 5 metacarpals, 14 phalanges, and a whole lot of love.
And that's it for the upper limbs of the appendicular skeleton.
Region 2, lower limbs.
Now, some might argue that the body's lower limbs are more important than its upper limbs. These guys, for instance.
The lower limbs are far more important than the upper limbs. No, they're not. I'll get you like a lion!
Well, regardless of which set of limbs is more important, the pelvic girdle is the cornerstone of all lower limbs. You probably know the pelvic girdle as the hip, but you probably don't know it personally, so let us explain. The pelvic girdle attaches the lower limbs to the trunk of the body. It's also a point of attachment for the muscles that move the lower limbs, and it even protects sensitive organs like the urinary bladder.
The pelvic girdle is made up of 2 bones called os coxae, which connect posteriorly with the sacrum and the coccyx. You remember the sacrum. It's a division of the vertebral column. Each os coxa is made up of 3 bones, the ilium, the pubis, and the ischium.
The ilium forms the major superior or upper section of the os coxa, or where you rest your hands on your hips when you're preparing for a big cowboy gunfight.
The pubis forms the anterior and inferior, or lower front, section.
And finally, the ischium forms the posterior and inferior portion of the os coxa. This ischium is the bone you sit on when you sit.
Now, the pubic arch is the angle between 2 pubic bones. It is inferior to the pubic symphysis, a joint that connects the 2 pubic bones. But don't worry about joints now. We'll talk about them later.
The pubic arch can be used to identify a person's sex. This is because the angle of the pubic arch in males is less than 60 degrees, and the angle in females is greater than 80 degrees. The pubic arch has a wider range in females.
Now, all the pubic girdle details aside, let's discuss the lower limbs, dude.
The lower limbs each contain 29 bones.
That's a lot of bones!
The lower limbs support the entire weight of an erect body. They have to be much stronger than the upper limbs so we can use them for jumping, running, walking, and devastating karate moves.
The lower limbs are separated into 3 regions: the thigh, the leg, and the foot.
The only bone in the thigh is the femur, which is the largest, longest, and strongest bone in the body.
The leg is made up of the tibia or shin bone and the fibula. Only the tibia bears the weight of the body, which is transmitted from the femur to the foot. The proximal end of the tibia, or top part, articulates with the femur to form the knee joint, which is protected by the knee cap, or patella. The distal, or lower end of both the tibia and fibula connect with the foot to form the ankle.
Notice any similarities? The femur is like the humerus of the arm, both long, both durable. The tibia and fibula are like the lower limb versions of the radius and ulna, and the ankle is like the wrist.
Next up, the foot contains 26 bones in 3 different regions. Those regions are the tarsals, the metatarsals, and the phalanges.
The tarsals are 7 bones that form the ankle. The metatarsals are 5 bones that form the arch of the foot. Finally, the phalanges are 14 long bones that form the toes. There are 3 bones in each of the 4 little toes and 2 in the big toe, or as some call it, the hallux.
And that's it for the lower limbs.
Section C, articulations.
Articulation is a fancy word for joint. Joints are sites where bones join together to make movement possible.
Joints are divided into 3 different functional classifications based on the degree of movement they allow. These classifications are synarthrosis, amphiarthrosis, and diarthrosis.
Synarthroses refer to joints that are immovable. Synarthrotic joints just won't budge. They just lock bones together. These types of joints are found in places like the cranium.
The classification amphiarthroses refer to joints that are slightly movable. They're not rambunctious or hyper, but they do move a little bit. These joints are found in places like the vertebral column.
And last, but by no means least, the classification diarthroses refers to freely movable joints. These are the types of joints found in upper and lower limbs.
In addition to all this, joints can also be classified by their structure. The 3 structural joint classifications are fibrous joints, cartilaginous joints, and synovial joints.
The first structural joint we'll talk about is the fibrous joint. Some joints have little fluid-filled spaces between bones. These little fluid-filled spaces are called joint cavities. Fibrous joints do not have joint cavities. Fibrous joints are joints where bones are united by fibers of fibrous tissue at their joint sites. Fibers. Fibers. Hey, it's fun to say fibers. One specific type of fibrous joint is called a suture.
Now everyone has sutures in his or her skull. These sutures are made up of interlocking or overlapping bone edges that are connected by short fibrous fibers. The term fibrous fibers may sound redundant, but hopefully it'll make you remember the name of the fibrous joint. 2 other types of fibrous joints are syndesmoses and gomphoses.
In syndesmoses, bones are connected at their joint sites by long fibrous cords or sheets. Fibrous, get it? You can find an example of this joint in the lower leg between the tibia and the fibula.
Another cool fibrous joint is the gomphosis. Gomphoses are the joints that connect the teeth to their tiny bony sockets in the jaw. They are attached with fibrous periodontal ligaments.
Are you catching a trend here? Fibrous joints use fibers. Another type of structural joint classification is the cartilaginous joint. Now, can you guess what substance connects bone to bone in a cartilaginous joint?
Cartilaginous joints are joints where bones are connected by plates of cartilage. Like the fibrous joint, the cartilaginous joint has no joint cavity. They are amphiarthrotic or slightly movable and are usually found in the axial skeleton.
You remember the axial skeleton. It's the skull, the vertebral column, the ribs. Yeah, you remember it. Well, a good example of a cartilaginous joint would be symphyses.
Symphyses are flat, frisbee-like discs of cartilage between the vertebrae. The proper name for these frisbees is intervertebral discs. Symphyses are also found between the vertebrae and in the pubic symphysis of the pelvic girdle.
The synchondroses are another fine example of cartilaginous joints. The synchondroses are joints made up of superflexible cartilage called hyaline cartilage. These joints can be found in structures called epiphyseal plates. Epiphyseal plates are found in long bones like the humerus and the femur. These plates allow for linear bone growth in places like your arms and legs. That's longitudinal growth.
The final structural classification is the synovial joint. These joints consist of bone ends that are separated by a joint cavity filled with synovial fluid. Synovial fluid is a liquid that reduces friction between bones. Synovial joints come in 6 exciting varieties: gliding, hinge, pivot, ball and socket, saddle, and condyloid.
The gliding or plane joint has a flat surface and allows for sliding movement in between bones. The gliding joints are found between ribs and vertebrae and in the joints of the wrists and ankles. The joints in the wrists and ankles are known as the intercarpals and intertarsals. Makes sense, doesn't it?
The hinge joint, found in the elbow and knee, is made up of the convex end of one bone that fits into a concave groove of another bone. Remember, convex bulges out and concave caves in. The hinge joint kind of works like the mechanical hinge you might find on a door. The pivot joint is another important joint.
It has a rounded surface that protrudes into a ring formed by a bone and ligament.
Pivot joints are found between your first and second cervical vertebrae, called the atlas and the axis. Remember, your cervical vertebrae are located in your neck, and the pivot joint is the joint that allows you to shake your head no.
The next major joint is the saddle joint. The saddle joint is found in the thumb and, oddly enough, looks kind of like a saddle. The saddle joint allows for both up and down and side-to-side movement.
You can find the ball and socket joint in both the shoulder and hip. It consists of a large spherical head that fits into a large concave cavity and allows for all types of movement, making it the most mobile joint. In fact, you remember the 3 functional classifications of joints? Synarthroses, amphiarthroses, and diarthroses? Well, the ball and socket joint is a diarthrotic joint because it's super mobile.
Finally, the condyloid joint, located in the knuckles and wrists, consists of a small condyle, or projection, that fits into a small depression and allows for side-to-side and up and down movement.
Well, there you have it. You are now a joint scholar. You know about the 3 functional classifications of joints, as well as the 3 structural classifications.
Joint injuries, joint disorders.
When studying joints in the human body, it is very important to take into account common yet very painful injuries. These include sprains and dislocations.
A sprain involves the stretching or tearing of a ligament, which unites bones at a joint. A sprain is extremely painful. Sprains can be partial tears or complete tears.
Partial tears heal very slowly because of lack of blood flow to ligaments. Complete tears must be repaired surgically, and surgery is very frightening, even if you can bench press.
Artificial ligament or a ligament from a cadaver.
Dislocations are also very painful.
When a dislocation occurs, bones are forced out of their normal position at a joint site.
Dislocation often occurs in shoulders, fingers, and thumbs. I have dislocated all 3. I am in constant pain. Dislocations are corrected by placing the bone in its proper position, a process that is very painful and very frightening.
Joint injuries are painful, but joint disorders are often prolonged and more serious. Arthritis is an example of a serious joint disorder.
Arthritis is a general term that refers to over 100 different kinds of inflammatory diseases. There are 3 common kinds of arthritis: osteoarthritis, rheumatoid arthritis, and gout.
Osteoarthritis is the most common condition. You remember cartilage, the flexible material found in joints and other places? Well, with osteoarthritis, cartilage is destroyed. When this happens, little chips of bone called bone spurs form, making movement extremely difficult.
Rheumatoid arthritis is another form of arthritis. It causes destruction of cartilage, fusing bone ends together so joints can't move anymore. You can imagine how painful that might feel.
Gout is a disease that's caused by a buildup of uric acid in joints. Uric acid is a natural bodily secretion, but in excess it can lead to the melding together and immobilization of joints. The most common joint affected by gout is the hallux, or big toe. Gout can be prevented by avoiding foods containing the nucleic acid purine, like liver.
Well, it shouldn't be that hard to avoid liver.
Sadly enough, we've come to the end of our journey through the skeletal system. You've learned about the axial and appendicular skeleton and familiarized yourself with the joints in those systems.
The human skull is made up of 8 cranial bones that surround and protect the brain, and 14 facial bones that form the underlying structure of the face and support for the teeth. With the exception of the mandible, the bones of the skull articulate with each other through joints known as sutures. Throughout the skull, holes known as foramina serve as passageways for blood vessels and nerves. Bones on the surface of the skull encase the brain, protect sensory organs, and serve as attachment sites for the muscles of the head and neck. These bones include the occipital bone, parietal bones, temporal bones, and the frontal bone, as well as the nasal bones, the zygomatic bones, the maxilla, and the mandible. Other bones become more visible only when looking inside the skull. The sphenoid bone makes up the anterior base of the cranium, It is a butterfly-shaped bone with a central body and two pair of laterally projecting wings. These wings form portions of the orbit. The body of the sphenoid features a depression known as the sella turcica, which houses the pituitary gland. Located between the orbits, the ethmoid bone makes up a portion of the cranial floor and also the roof of the nasal cavity. An inferior projection, the perpendicular plate of the ethmoid bone, forms part of the nasal septum. The crista galli projects superiorly from the ethmoid bone and serves as the attachment point for the falx cerebri, a dural fold. Extending laterally from the crista galli is the cribriform plate, a perforated area through which the olfactory nerves pass. The two L-shaped palatine bones form the posterior third of the hard palate, part of the nasal cavity, and a portion of the orbit. The small, thin lacrimal bones make up the anterior portion of the medial wall of each orbit. A groove known as the lacrimal groove helps to form the nasolacrimal canal, which contains a duct that allows tears to travel to the nasal cavity. The vomer is an elongated, plow-shaped bone that forms the inferior and posterior part of the nasal septum. The internal and external skull bones articulate precisely, forming an intricate structure perfectly suited to its functions.